Hello, and welcome to SAGE's virtual annual meeting 2020. This is a session of the Acute Care Surgery Joint Symposium, and I am Glen Tinkoff, and will be speaking on management of the open abdomen after emergency general surgery. I am the System Chief of Trauma and Acute Care Surgery at University Hospitals here in Cleveland, Ohio, and a professor of surgery at Case Western Reserve University. I have no disclosures. I will be using words such as VAC and Whitman patch in the lecture. It's hard to not do so in this topic. The objectives are to outline the indications for an open abdomen, discuss temporary abdominal closure method, review patient and wound management, and discuss the management of entero-atmospheric fistulas. The information contained in the lecture is predominantly from two evidence-based sources. The first is a two-part series from the East Group, and the second from the World Society of Emergency Surgery, published in 2017. Definitions to keep us on the same page. Open abdomen is a surgically created defect in the abdominal wall that exposes abdominal viscera and requires temporary abdominal closure measures. Damage control laparotomy is a truncated laparotomy with the goal to quickly provide life-threatening temporizing measures. Abdominal compartment syndrome is a sustained intra-abdominal pressure of 20 millimeters of mercury that is associated with new organ dysfunction or failure, requiring consideration for a decompressive laparotomy. Indications for damage control laparotomy in emergency general surgery are non-traumatic intra-abdominal hemorrhage, such as a visceral aneurysm rupture or a surgical misadventure. Physiologic derangement in a patient undergoing a laparotomy for severe intra-abdominal sepsis can occur and is managed similar to the trauma patient, moving back to the ICU and then a second look or re-laparotomy. Also in patients where there's concern regarding source control or deferred intestinal anastomosis, such as one that would be placed in a soiled peritoneal cavity. Acute mesenteric ischemia, with especially after bowel resection. A second look is and the deferred intestinal anastomoses are a standard. In regards to abdominal compartment syndrome and decompressive laparotomy, emergency general surgery patients and etiologies are many, intra-abdominal sepsis being one of them, intestinal obstruction in ileus, vascular emergencies such as ruptured AAAs and mesenteric ischemia, especially those undergoing massive resuscitation, acute necrotizing fasciitis, and secondary abdominal compartment syndrome in patients such as a burn patient or some patient who's underwent a hemorrhage from extra-abdominal sources. Really, there's only one major approach at this time that's preferred for temporary abdominal closure after the index operation. That is the vacuum-assisted closure dressing that may be homemade or commercially available. This is made up of 3 layers with a visceral protective barrier on top of which macroporous material with suction are applied, and an inclusive adhesive sheet is placed to contain the entire dressing. If not available, a Bogota bag in this image a IV bag cut on seam can be sewn to the skin or fascia as an alternative. Any plastic sheeting can be utilized in this manner. As to patient management, this is garden variety surgical critical care. One manages the initial insult, continues the balanced resuscitation once the patient's in the ICU, correct the coagulopathy, acidosis, hypothermia, monitor hemodynamics and points of resuscitation, and provide antibiotic therapy in broad spectrum fashion as needed. One must be prepared for reperfusion injury or ongoing hemorrhage, which might warrant take-back, recurrence of ACS, which might warrant reopening at the bedside, and onset of multiple organ dysfunction syndrome, and initiation of organ support. One must initiate nutritional support as soon as possible, as these patients are significantly catabolic, losing 2 to 4 grams a day of protein from their open wounds, their open abdominal wound. Enteral feeding is preferred if access can be obtained. A second look should be undertaken within 24 and no later than 48 hours. AAST provides a comprehensive algorithm to wound management, which will be reviewed in the following slides. Most patients can be managed with early fascial closure on the takebacks, generally by the third reoperotomy. And if achieved, and it can be in about 60% of cases, this is associated with decreased mortality and complications. Closure can also be achieved in patients with fairly wide wounds, using delayed techniques such as vacuum-assisted closure devices with or without serial dynamic suture closure, or the Whitman patch with its set of adjuncts to achieve fascial closure over generally the second week. These are relatively safe and are used up to the third week, and in many cases and many series have high success rates. If fascial closure cannot be attained, fascial bridge closure with an absorbable biologic patch is recommended. One should avoid a permanent synthetic. Skin or soft tissue, split thickness skin graft can be used over a relatively clean bed. And component separation is not recommended at this time, as this is a once and done management strategy, and is better strategically done in a delayed fashion. This patient population is subject to both numerous systemic and wound complications, but probably the most dreaded of which is the entero-atmospheric fistula. This is due to the vicious cycle of these wounds of lack of coverage, visceral exposure, and presence of synthetic material. The longer these wounds are open, the greater the risk of entero-atmospheric fistula. The incidence is reported about 6 to 17%, but it's likely much higher. Once these occur, patient mortality, length of stay, and cost increases dramatically. The AAST evidence-based review provides this simple algorithm, which will be reviewed. The management begins with source and sepsis control, providing nutritional support first parenterally and enterally if possible. Local wound care is important and must be daily in many cases initially. Vacology has transformed the field, and the use of floating stoma as depicted here can help compartmentalize the wound so a split thickness skin graft can be achieved and a temporary abdominal closure provided. Definitive repair should be delayed until this graft is pinchable off the surface of the intestines below or viscera below, and it can be accompanied with a abdominal reconstructive effort. This is generally after 6 to 12 months of recovery. In summary, damage control laparotomy and decompressive laparotomy are life-preserving emergency general surgery procedures. Vacuum-assisted closure devices are preferred as temporary abdominal closure in the index procedure. Open abdomen patients require comprehensive clinical care. Early fascial closure can be achieved in the majority of these patients. For those in which it cannot be achieved, applying delayed fascial closure methodology is important and can lead to closure in as much as 90% of these patients or more. If unsuccessful, fascial bridge closure is preferred using either absorbable mesh or a biologic patch. And the entero-atmospheric fistula is a serious avoidable complication. One should delay definitive repair for 6 to 12 months after the index surgery and consider abdominal wall reconstruction at that time. Thank you for the opportunity, and I will be available in the panel for any questions.